Health outcomes. Changes due to interventions. To bring positive change, patient experiences and health must both improve. Healthcare costs must be lowered, and clinician and staff burnout has to end. But our problems are big. 133 million Americans have at least one chronic disease. 500,000 people are dying every year from hospital errors, injuries, and infection. The shortage of primary care professionals will be as much as 100,000 in just the next 5 years. Big problems require bigger solutions. Positive change needs acceleration. It needs to happen now. But these are not so easy solutions that many don't want to hear, and even few are willing to talk about. How to lead such a change? How to discover, discuss, and disrupt healthcare to make a difference now? This is VITALS, Visionary Health Leadership in Action.
Well, good afternoon and welcome to VITALS. I'm Dr. John Langell, the president of Northeast Ohio Medical University, and I'm pleased to bring you VITALS in collaboration with the University Hospitals of Cleveland. VITALS is an open forum to hear from today's national leaders that are using the VITALS tools to transform healthcare. VITALS is an acronym representing value, innovation, technology, advocacy, leadership, and service. Today, we're going to do VITALS a little bit differently. Typically, we hear from our transformational speakers for a few minutes and then engage into a question and answer session. But today is the first VITALS of the academic year with 211 new first-year medical students attending to learn about healthcare leadership. So today we'll be running this as more of a fireside chat. Our VITALS transformational leader today is Mr. Daryl Tol, and he will be moderated by Monica Robbins, the senior healthcare correspondent for WKYC News. Daryl's lead at HATCo is to be the strategic head of partnerships for healthcare systems across the country, including our own Summa Healthcare. Prior to joining HATCo, Mr. Tol was the president and CEO of Advent Health, one of the largest and most impactful nonprofit healthcare organizations in the country. His experience at that institution, in addition to his other experiences and training, have really set him up to be a key leader for the transformation of healthcare within the United States. He is a graduate of Walla Walla University and of Loma Linda University, and these areas of training and expertise have made him a transformational healthcare leader. With that, I ask you to please join me in welcoming Mr. Daryl Tol to the stage.
Thank you so much, Dr. Langell, and welcome to all of our new medical students. And I want you to understand, you are listening to a game changer here today. So I want you to listen very carefully because we really want to hear the questions from you today. So Daryl, let me start with this. Start by describing what General Catalyst is, the types of companies that it invests in, and while you're at it, explain what HATCo is.
Sure. It's great to see everybody. This is a great space here. General Catalyst is a large venture capital firm that invests in a number of spaces, but healthcare is the biggest and, of course, the favorite space, right? Of course it is. General Catalyst invests in startups, which means you take a small percentage of a company and you put money in to help them grow, and some of them make it and some of them don't. And the leadership at General Catalyst years ago thought, that's not going to work to transform healthcare because each of these tiny companies by themselves just create fragmentation. They aren't connected to anything. They aren't integrated to anything. They don't change the practice of medicine by themselves. So what do we need to do to really change healthcare? Well, the first thing we decided was we better start spending a lot of time with health systems and physicians and nurses on the ground. So we started partnering with systems. We now have 32 systems in the country and even 4 around the world that we partner with to learn from and build a transformation thesis. We got into that partnering model and we thought we really have to climb in the trenches and run a system or we're just talking heads. We're just doing this. Like we're just imagining that we're very brilliant and that we have transformational ideas. We better get in the trenches. So we formed this company called HATCo, which is a funny name, but it stands for Health Assurance Transformation Company. And health assurance is our word for healthcare of the future. Assuring health versus all the things you know are broken about today's model. So HATCo was formed in order to forever exist, not to be a venture investment for General Catalyst, but to be a forever evergreen, we call it, investment that changes healthcare. So we started looking for health systems, and we quickly decided Summa Health was the very best system for us. And we closed on our acquisition of Summa on October 1st of last year. So now, not only do we have a lot of cool companies, but we also have a health system, and we're very passionate about doing real transformation there.
What was it about Summa that made you guys look at that particular system?
We're really interested in total transformation, which means the systems we looked at had to have a payer and a provider. So an integrated payer and provider allows you to really innovate across how people can afford the healthcare all the way through how they experience the delivery of healthcare. We also, this is an odd one, but we wanted a health system in a difficult market. The reason is healthcare leaders don't like change, and they're going to dismiss it easily. So if we picked a system in a great market, oh, it's growing, a lot of rich people live there, people would dismiss it. They'd say, those jokers, they just picked a place where it's easy. So we picked a place where it's hard. Summa Health isn't hard because it's not a great system. It's hard because this area is not growing. This area has a poor payer mix. There are a lot of people without coverage and without assets and resources. And this area has a number of healthcare access issues that we recognized. So we were very excited about that profile. And the system itself needed to be a community asset, meaning providing all of the services as a meaningful or leading healthcare system in its community, rather than just a 150-bed hospital on a corner surrounded by bigger ones. So we wanted a system that was, in our case, Summa is the leading health system in the Akron area and Summit County, and we thought that's perfect. We're the safety net. We do everything. We're the trauma center. That's what we want. We want to transform that kind of system in a real American community that has all the struggles everybody has. And if we can, when we can, then that story is highly credible.
Let's go back to health assurance, because those are two words that a lot of people in this region really need and want to hear. So what is it? What does it mean for health systems and the communities they serve?
Well, I think one of the biggest blind spots in healthcare is that we do a great job, for the most part, when people are right in front of us. When they're in a hospital bed, an emergency treatment room, or an exam room in a doctor's office. And we do a terrible job when people are not in one of those places. So everyone here will go work in a place, a building, most likely, and those interactions will feel great. And everyone will feel like, I'm a great physician because I just had a great 3-minute interaction with a patient. The fact is, the real struggle happens between those moments. 3 a.m. in the bathroom, alone at home. That's where the struggle is. That's where the healthcare risk is. That's where the safety issues are, and none of us measure it. You won't find a health system in America that measures the quality and safety issues between visits. We just proudly spout our quality and safety stats during visits. That's a brokenness in the system. That's terrible because we all experience healthcare every day. We experience our thriving or our suffering every day, and we experience it largely alone or with our close family members. So health assurance means, okay, forget that institutional model. How do we think about being always connected, staying always on, assuring not just that you have a lifelong partner in health, but that you actually have the tools that allow you to stay connected and the guidance systems that allow you to make decisions more easily, and a healthcare system that, imagine it, takes the burden off of you and carries it for you instead of asking you to do all the hard work to try to get in.
That's sounding like technology will be needed. So what about affordability there? And how are you going to use those analytics to further your mission?
Yeah, technology has to be part of this story. Let me tell you a story from 3 weeks ago. One of our team members, we have started calling every single human being that comes in and receives hospital or emergency care the day after they leave. So everybody who has been in Summa Health gets a phone call the day after they leave. And one of our team members, her name was Rachel, she called this lady who had been in the emergency room the day before. They had a 26-minute conversation. That's a long conversation, 26 minutes. During that conversation, it was discovered that this lady had 10 out of 10 leg pain. This is the day after the emergency visit. 10 out of 10 leg pain, swelling in her leg, substantial swelling in her leg, and couldn't get to the bathroom in her house and had no support system. So during that 26-minute conversation, this individual, a series of interventions happened where we were able to get her transported to an inpatient rehab facility. She couldn't handle this by herself and was at great risk alone at home. Most health systems are not doing this and would not have discovered that. The interesting thing is Rachel is AI. Rachel is not a human being. Rachel costs us 10 cents an hour. Call centers cost about $70 an hour. You can't call everyone when you're paying $70 an hour. You can if you're paying 10 cents an hour. Now, Rachel wasn't doing diagnosis. Rachel wasn't doing clinical treatment. Rachel was having a human conversation with another human being and identified risk as a result. Now, just in your minds, of course, you can leap to all of the opportunity there, all of the opportunity. So that's technology, but in a way, it's just staffing. It's doing things we've never been able to do. It's abundance. It's the creation of opportunity. It's not adding cost at 10 cents an hour. It's plummeting the cost of doing the kinds of things we should have been doing as a system for a long time. And Rachel is calling seniors to do check-ins now. Rachel is talking to people who have chronic illness and checking in on their treatment progression, whether they got their pharmaceuticals. Rachel's very busy, but Rachel can make 1,000 phone calls at the same time. Rachel is not like humans, not limited in the way humans are. When you think about assuring health, you have to have new leverage because in the intro, you saw 100,000 physician shortage in primary care alone, I think was the stat. There are numbers across some people say 13,000, some people say 86,000, some people say 100,000. But at the end of the day, there are not enough doctors or nurses for us to be entirely human powered, period. And no matter how big NEOMED gets, we will not produce enough through human training. We will have to change the way medicine happens and the kinds of tools you have available to you. There's only so much you can have in your brain at any one time. You can memorize all you want here, but when that individual leaves your office, you can't call them at home and check in 100% of the time. You don't know what happens. You don't know what happens tomorrow. You don't know the suffering that exists. You will have no way of knowing. You are incapable of knowing. And so how do we create tools that help you, not replace you? We don't have enough of you, but how do you create tools that make you smarter, better, and always on without exhausting you and burning you out, which is happening today? So we're focused on a whole person, human-led, technology-enabled view of a future of healthcare, which, by the way, the math says has to happen, is not optional.
Does Rachel have training in social determinants of health, and does Summa have the model in place to deal with those specific things?
Yeah, Rachel has trained across millions of, by the way, Rachel could beat you on your boards, could beat the pharmacy boards for the pharmacists, can beat the nurses at the nurses boards. Rachel outscores, this is funny. So we do We do what we call pressure testing or red teaming of these models, and hundreds of millions of dollars have been spent training the models. But Rachel outperforms our human staff on patient satisfaction. They like Rachel better. They probably like Rachel a lot better than their doctor. They love Rachel. But even more interesting, when we were going through testing of Rachel, one of the questions was, a real nurse would not have said that. So we had a script and we had real nurses and we had Rachel calling and doing conversations. And then the test group, thousands of people, would say, at this point, a real nurse would not have said that. Real nurses said things real nurses wouldn't say more frequently than Rachel did. Isn't that hilarious? I mean, people were like, a real nurse wouldn't say that, and it was a real nurse. We're finding that with the right information, these tools get very smart very quickly. They learn things. They need to be supervised. You need to do just like you did. By the way, humans are imperfect. You know that, right? Okay. So human teams make mistakes. Human teams treat people unfairly. Human teams say erroneous things, including the most brilliantly trained doctors. So when you're comparing AI to humans, you're not going for zero. You're going for better than humans. And it's not that hard. It's sad that that's true, but it's not that hard to be better than humans. But you've got to be well supervised and you have to know what you're building.
What recourse does a patient have if they think Rachel's not working?
So Rachel says at the beginning, I am artificial intelligence. It's not a trick. It says right up front, are you willing to talk to me? And the average response, I can listen to these calls, the average response is, cool. Like on the phone, you hear people, what? Yes, I'd love to. And some people play a little bit with it to see if they can stump Rachel, which they can't. But they like on average, they love it. One guy said, is this Iran? And hung up. But other than that, like a lot of people really love it. And if Iran has this technology, we're in trouble. So I think we're okay. When people want to bail out, now, first of all, Rachel advances to a human based on the triaging the conversation. So Rachel will immediately pull a nurse in or even a doctor in based on where the conversation is going. Rachel doesn't try to handle complex clinical situations or suicidal ideation or something. There's an immediate path to a human being. We don't trust Rachel enough to do that. Eventually, these tools will get more and more trusted, but today we're not there. So that's important. And people can also say, hey, now this is not the dumb bot. You go through the phone trees or you talk to the dumb bots and you're probably like me. You're like, agent, 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 just give me an agent. Rachel isn't like that. Rachel's like talking to a human being, immensely brilliant, understands you'll just have to try it sometime because it is an amazing conversation. You get lost in it. It feels like real relationship. It feels like a real person. So we rarely have a person say agent because they can, and if they do, they'll get to somebody, but they're generally quite pleased with the trajectory of the conversation.
Let's move on to leading through the changing and volatile healthcare environment, and something that I'm not sure our audience is aware of, but private equity now owns about a quarter of the nation's health systems and hospitals. Is that the future? Is that where all of healthcare is going?
No, we actually don't like private equity, just to be honest about it. So we distinguish very carefully between private equity and venture capital. Venture capital invests little bits in small startup companies and uses the power law because some of those will win and that creates returns. Private equity buys things, re-engineers them through cost cutting and layering on debt, and often is a destroyer of industries. And so, they killed Kmart, they killed Steward Health, they killed, private equity is toxic often in the classic approach. So we don't like it. And we don't like private equity ownership in healthcare, largely because it brings that toxicity into this. It's not transformational, it's just financial engineering. And that's a lot of what's broken healthcare anyway. So what we're looking to do is say, we bought Sumo, we put in the purchase agreement, we're here indefinitely. So we're not trying to flip it. We're trying to run it and allow it to thrive, and come join us, please, because this is fun. This is really amazing what we're doing. But the opportunity is there for us to show there is another way. And I don't think it means every health system has to be, there's only one venture company in the world that's ever done this. So it's not like there are a lot of these things going on. This for us is an important moment to demonstrate to the industry, the not-for-profits, the for-profits, the government health systems, that there is a new way to do healthcare, and we want to evangelize. We hope they copy us. We hope our tools can be useful. And so we're not zero sum. We want to work with everybody to help healthcare become better. And there's some returns for us in that too, for sure, we think, but it's not about the kind of private equity model.
A lot of people depend on, especially the community, depend on what the hospital is going to do for them. So how do community-based and rural health fit into HATCo's strategy?
This is a perfect time actually for community-based and rural health, because if you rely on people, it's very hard to serve every market at a level of adequacy. Montana has 70 psychiatrists. You think that's going to work for Montana? It's not. It's not going to work for Montana. Montana could have significant virtual behavioral support for their population, supporting the 70 psychiatrists, and all of a sudden the situation gets better. Just gets better for real people who just need counseling. And those counselors don't have to live in Bozeman or Billings. They could live in Indianapolis. This is an immense moment. So we think about rural markets around health systems in more urban markets as a rural ring. How do you serve the rural markets? There's no magic that will save a rural hospital in a town with not enough people. There's no government program or magical donation that will save that. It will fail. A hospital won't survive in a town of 2,200 people. So how do those 2,200 people access health services? Well, that's where in-home care, virtual care, care extenders, various tools that we're looking at create a rural ring, and actually could create an enhanced access model for rural markets that's even better than what exists in some cities where everyone thinks they have to wait 6 weeks to see a neurologist. People in rural markets will probably see a neurologist today. That's actually quite a bit better, and I think we're going to be able to do that.
Yeah, how are you fixing that problem? Because that's one of the biggest issues everyone has. And if we don't have enough doctors, if we don't have enough providers, how will SUMA fix that?
Yeah. Well, there's a significant culture change needed that starts with rooms like this. And let me just talk through this a bit, because this is very important. It's amazing how many meetings I have with doctors where the following is said. The way things work today is terrible. Don't change anything. There's a definition for that, right? That doesn't work. The reason that everyone's burning out and frustrated and not telling their kids to go into medicine, the reason that consumers are frustrated is because the system is poorly designed and it needs to be redesigned. So when you follow that with don't change anything, you're an idiot. You have zero insight. So this is very important, and we have to call this out. And we have to look at rooms like this and say, you can be the foundation of a future that's much better than today, but only if you embrace change and new capabilities. And we need some small group of people to do that, to be the inventors and developers and pushers for the future of healthcare and the way that that can work. The reason that's important is because we're attacking sacred things. Let me just lay 3 sacred things out there. 1, we have a cult of expertise in healthcare, which creates the iconic physician dynamic. Anything that becomes iconic or a dependence creator creates a bottleneck. So if you have 1,000 people trying to get through a bottleneck, they're going to back up. And that's happening all over the country right now. Now, the iconic physician is very proud. Why? Because their practice is busy every day. While they're destroying human lives in a way by closing the door and being a bottleneck, they're very proud because they're on billboards and their practice is busy. We can't have that mindset. The fact is, healthcare is not about iconic moments of expertise. It is about a coordinated, team-based model of care in which people like us are willing to become nobodies that are part of the whole. The moment we become nobodies that are part of the whole, we can care for people across a lifetime. I hope a lot of you don't want to develop your expertise too much, because experts get narrower and narrower and narrower and are useless for broad transformation and very useful for pinky surgery or whatever. But there is this need for the broad thinkers in healthcare to deal with this expertise problem. It has to be resolved. There's a second challenge, which is healthcare is a lot like religion. Tradition, routines, they are treated as sacred. Now, there was a time when the church in religion wouldn't even give people Bibles, right? Because the religious people didn't want the people to understand the mystery. It was a manipulation. But the same thing happens in medicine. We don't want people to have the Bibles. So people are going on their own to ChatGPT and Claude and their own tools, and they're double checking us. They're getting second opinions from AI. We're not giving that to them. We're too arrogant to. And we're sticking in our protective language all the words that you memorize in your books that humans can't understand. Just like the priests in the religious systems of old that prevented the population from understanding the mystery. It's deeply, deeply problematic. The people that need to understand our language the most are the people who are receiving our care. Period. End of story. And we should be providing the tools that allow them to interpret what we say. So as we think about your question, how do you create health insurance? How do you change this experience? You're confronting 100 years of dysfunctional mental development and system development that has to be redesigned with people who are excited, frustrated with the current state, disappointment drives innovation, and then excited to be part of the transformation. And if you're in medicine to be an iconic, famous physician who's on a billboard and drives a Maserati, I would say you're going to be worthless to the future of healthcare. If you're here to be part of a team and a thriving team, and you're willing to go against the religious dogma and orthodoxy of medicine, and you're willing to go against the white-haired people you will round with who try to tell you AI is never going to work and is terrible or whatever, you've got to resist that, and you've got to be that voice that says, hold on a minute, there are fundamentals here that just aren't working, and it's not about us. And I think when that starts to happen, it's going to be really cool.
I don't think they're going to have a choice about AI, though.
There's no choice. It's like saying, let's keep Walmart from coming to town. Walmart comes to town, whether you protest or not. AI is here.
Let's open it up to our medical students. Feel free. There are microphones in the middle of the aisles. Please make your way to a microphone and ask your question.
Only easy questions, though. It's the rule.
Okay, so with Rachel taking over a bunch of the phone calls and everything post like emergency department visits, do you think not having that human connection after is going to impact patients negatively?
Yeah, let me be clear. There was no human connection after.
Do you think like having the AI connection after, because I know in the emergency department, lots of people come in with mental health related concerns.
Yeah.
Do you think talking to AI after having a significant mental health episode is going to be beneficial?
Yeah, absolutely. The early studies show that it is, and that it is not always. If someone's in the middle of a psychotic break, it's not the best time to talk to AI. But for the most part, depending on diagnosis, it's very, very effective. One of the best uses for these tools is where we've never been able to do something that should have been done, to answer your first question more thoroughly. So Rachel is making calls that no human has ever done and is not doing at any health system today, or any doctor's office today for the most part. And that creates safety, that creates connection where there was none. And we think those are the best early cases until we know that it works well, because it's low risk and it's creating connection instead of replacing human connection. We actually haven't used it anywhere to replace human connection, and I'm not sure that's even the best use of it. Great question.
Thank you.
You're welcome.
Let's go to this side.
I know you mentioned that Akron has a challenging payer mix. I was wondering what your opinion is on some challenges or opportunities you see in the future with respect to government payers for the Akron area.
Yeah. I'll speak for myself. We have no faith in government to solve these problems. I'll just full stop. We think it'll be up to us, all of us, to solve these problems. Government will play around the edges, and we'll try to innovate, and we do try to advocate, and we do try to speak for better and for better models. We think there's a lot of work to do to innovate around traditional Medicare. Medicare Advantage is very significant here. We think it's a good model and can be better. We think a number of people who are covered by insurance through their employers will go down, and it has been, and we think that will continue. There's something called ICHRA, where employers are starting to give people just a lump sum of dollars and say, go buy your own insurance. That we think will grow. Unfortunately, people may not buy their insurance and they'll come in uninsured. So we think uninsured will grow. HR 1, or the One Big Beautiful Bill as it's called, will cut Medicaid enrollment in the state of Ohio and will reduce the people who have coverage through the exchanges. So we think we're facing a future where people will have fewer and fewer resources, poorer coverage, and find access more difficult unless we have a way we can coordinate care for those individuals who have those needs. And we're thinking a lot about that.
Thank you.
Yeah, great question.
So Rachel is definitely a very, very interesting piece of technology. I just want you to speak a little bit more about how, given that Rachel is AI, I just would wonder if you could speak more about how it implements protection of, say, patient privacy and patient interactions, given that it is AI and presumably this data may or may not be used to improve future interactions.
Yeah, it's important that when you're using AI, it's in a container. You're not having Claude talk to patients or something that may actually leak out. So every patient interaction is as secure as your EHR interaction or anything else, because it's contained. It's essentially impossible for that information to get out of the box that Rachel is in while talking to that patient. It's interesting to think about the security implications of the future use of AI and how that use grows and what that looks like from a cybersecurity perspective. I think AI is like the internet. It's terrible and it's wonderful, right? You can do deeply dark and evil things on the internet, but you're probably glad it exists because you can do bright and amazing and life-saving, life-changing things on the internet. So AI is the same way. So who uses it? How do we harness it? How do we protect it? Instead of being afraid of it, there's a great quote I heard, which I think helps with your question. Consumers are adopting AI tools at the pace of their frustration. Physicians are adopting AI tools at the pace of their fear, and they are losing. Isn't that a great quote? Anytime you feel defensive and you feel like there's so much risk, but your customers are adopting it, you're getting less and less relevant to them. And I think it's a dangerous trend. So we need to figure these things out, and we can figure them out. By the way, Rachel has 19 supervisor agents. So Rachel has multiple personality disorder. Rachel has 19 supervisor agents that all sound like Rachel. But if I ask Rachel a question about a pharmaceutical, a supervisor agent that only knows the Merck manual jumps in and has the pharmaceutical conversation, period. Rachel can't freeform. There are 19 different categories where those supervisors control the conversation and then jump back out of it. And the consumer doesn't know. It just sounds like the same thing. So it's fascinating. You should come over. We can show you how it works.
Yeah, I may take you up on that offer.
Please.
It's definitely a piece of really, really cool piece of technology.
We have 12 AI builders on the ground full-time at SUMA right now, and y'all could come hang out with them. They'd love to learn from you, but you'd probably learn some things from them too, like I do.
Thank you.
So I just wanted to go back to those core issues that you were talking about in medicine currently. That first core issue you mentioned where medicine needs to be broadened. I kind of wanted to ask you, how would you interpret the issue for more niche surgeries or more niche treatments? And is there more of a happy medium between going broad and remaining niche? That way we can provide optimal treatments to as many patients as we can.
Yeah, absolutely. I would want my heart surgery from someone who does a lot of them, right? So I really appreciate expertise. But I think the heart surgeon is less important to me than the primary care doctor. And I think in our medical culture, it's the opposite. Now, I don't care how much money the heart surgeon makes or the primary care doctor makes. That's kind of up to them and economics and whatever. But as a human being, my most important clinical relationship is not that occasional expert interaction. And it annoys me when every health system markets with pictures of helicopters, stretchers, and operating rooms. Consumers don't want to see that. They don't want to be in a helicopter. The helicopter is the worst day in your life. It's the worst day in your life. What a terrible advertisement, right? Thriving is what we're about. How do we reset this? But it's the helicopter because we worship the expertise, right? And the shininess of that. And that mindset, it's deeply baked in. It may even be baked into why you're here, some of you. And it's really problematic for the future of healthcare. And I hope we can at least flip the script, honor the expertise, but we've done consumer testing. Consumers would rather have a well-coordinated experience with nameless physicians than experience a series of delays to see named famous doctors. Universally, this is true. So the more we realize that, then we can develop trust-building brands that span an entire lifetime of care versus individual power structures that sometimes in human power dynamics we seek after. It's a great question.
So you talked a lot earlier about patient satisfaction with Rachel. I was wondering if you've done any research onto how physicians, nurses, and other healthcare providers feel about Rachel being implemented, and in what ways do you think that Rachel may become an asset to them in their practice?
Yeah, so far, first of all, everyone reacts initially with nervous fear, and then, it has to prove itself, right? Which I think is normal and okay. We've tried to create tools that physicians don't normally have. So, for example, when Rachel has a conversation with a person, the physician gets in their health record, they get a pre-visit summary that summarizes those conversations. The physicians are like, this is so cool. I've never had access to this information. This patient's never talked about this with me. They've been in here over and over and over again, and they never mentioned whatever that they talked openly with Rachel about. So now the physician asks the patient, you talked to us about this. You've never brought it up. Can we help you with that? And all of a sudden you have a new course of treatment that individual needs that you wouldn't have had before. And doctors are saying, why didn't I even think that was necessary? This is huge. So as those things start to show up, people's light bulbs start going off. I had a primary care doctor come up to me and say, I could envision a future where I'm supervising 4 AI agents in my clinical model, and maybe I could see 100 patients a day and not feel burned out. I was like, you're onto something. Guess what that would do, by the way, to the shortage math? The shortage would disappear. If what that physician, now that physician's guessing, he doesn't know what reality is going to look like. But if that were possible, there would be no shortage. We got to think about these things.
Thank you.
You're welcome.
Thank you for speaking with us today. My question was regarding your use of AI as your primary model for going above and beyond to access the general population. Why choose an AI professional rather than creating, say, a new job market with trained professionals instead?
We can't afford it. Healthcare is too expensive already. So if we had to hire, in order to do, we actually calculated this number. If we wanted to do always on care navigation for our customers, for all of them, not just some of them, all of them. And if we did the normal healthcare model where you say, well, at least a nurse has to do that, we would need 11,000 nurses at SUMA to do it. Which, by the way, SUMA would close in 2 weeks with that level of staffing, whereas the AI can do it very, very quickly and readily. So it's a structural impossibility would be the short answer, to hire people to do all that. Yeah, great question.
Hi, thanks again for speaking with us. So my question is more future-based. A lot of major innovations throughout the last 100 years or so have had a lot of benefits, but also a lot of downfalls. So as someone who creates or works with AI in the healthcare system, what unintended consequence of AI do you envision happening, or how would you address that?
Yeah, you're right. There are many unintended consequences. We all love our iPhones, but now we're all addicted to them and we can't look at each other, right? So there are downsides that I think have to be mitigated. If AI is built well, I'm less worried about the capabilities of the technology because I think responsible users will make sure that they're effectively trained and tested and approved, similar to therapies or whatever the case may be. And I think that we'll be reasonably comfortable with that. I think the unintended consequences have to do with, for example, I use a lot of AI tools in my work, right? You probably have started to, I hope, work on those things. If not, you should, because you should understand AI. But I use Claude Cowork, and we have to be really careful to maintain our own thinking ability and our own reasoning ability. And it's easy to create a series of shortcuts that it's like watching 8-minute videos on TikTok all day reduces attention span, and you can't read long form articles. That's a loss. That's a knowledge loss for humans. And I think AI could multiply that effect. And I don't think we should take that lightly. That's a huge consequence in any knowledge work, among others.
I'm being wrapped up for time. Do we have time for one more question? One more question, you, sir.
So first of all, I just want to say I'm on board with AI. I have an edtech startup, and we're focused on building AI and servicing AI workflows and enhancing them for education. So given your views on AI already outperforming physicians on many of these tasks and board exams that we're about to take, and that patients are increasingly comfortable talking to AI first, what would you tell an incoming medical student to prioritize over the next 4 years to stay ahead of that curve? Especially the aspects of do we need to change what medical education looks like today fundamentally?
Yeah. I'm not a medical education expert for sure, so that's a dangerous question. But I do think the amount of the expectation that you will memorize massive amounts of information and hold it in your mind when guidance systems and capabilities are going to be so sophisticated and ever present in your practice probably means your medical education could shift to less memorization and more experiential and exploratory learning. That's the extent of my non-expertise, but I think there is some opportunity there. Second, I think your education should include AI. It should include AI. It should include tools. And I don't mean as cheats, but I mean as encouraged ways to become familiar with this ever-changing landscape. And I think people who don't have are developing blind spots around what's actually possible and how fast this is developing.
Thank you.
I apologize. That was our last question. However, you have the last word. So any final thoughts you'd like
I
to
love
give?
having the last word.
Yes.
This is great. Really enjoyed this. This work is really important, and it has to prove out in a real place, and I'm excited about that happening. The way I view it is this is a purpose-driven rebellion, and we need more rebels. We have a gift in our hands. Healthcare is too complicated for traditional software and hard-coded things to have served us well. Even though we have electronic health records, those are very clunky and not very helpful for consumers. So I think we should accept this gift, take it as a deep responsibility, and search within ourselves and then go outside of ourselves and really think about what this work is all about. And I would encourage everyone to have a North Star, and that North Star should never be you.
Great advice. Daryl, thank you so much for everything you're doing.
Daryl, thank you for an amazing and thought-provoking conversation. I think all of us are thinking differently about the future of healthcare, and what you're doing now is truly transformational. This may be actually the most thought-provoking Vitals that I've had an opportunity to attend. Monica, thank you as always for your expert moderation. We've truly enjoyed this opportunity. Please join us in August when we will hear from Dr. Jessica Zitter, an active physician and a filmmaker who is getting out the word on transformation of healthcare through the social determinants of health and taking care of patients from their unique backgrounds through her latest film entitled The Chaplain and the Doctor. Until next time, stay active and engaged. Thank you.
Health outcomes. Changes due to interventions. To bring positive change, patient experiences and health must both improve. Healthcare costs must be lowered, and clinician and staff burnout has to end. But our problems are big. 133 million Americans have at least one chronic disease. 500,000 people are dying every year from hospital errors, injuries, and infection. The shortage of primary care professionals will be as much as 100,000 in just the next 5 years. Big problems require bigger solutions. Positive change needs acceleration. It needs to happen now. But these are not so easy solutions that many don't want to hear, and even few are willing to talk about. How to lead such a change? How to discover, discuss, and disrupt healthcare to make a difference now? This is VITALS, Visionary Health Leadership in Action.